Thanks, Mike, and good morning, everybody. What a great assembly. This is really interesting. As many people who know me, I'm a wireless technology guy for 2 decades and did all kinds of fun stuff around the world. And in that journey, I developed type 2 diabetes myself. So I kind of affectionately joke that the 2 things that define me, one is good, wireless in my blood. One is not so good, which is too much sugar in my blood as a type 2 diabetes patient. But somehow Welldoc has managed to fuse the 2 together. But what we're going to be talking about today is how do we harness the value of real-time sensors, if you would, in the management of a chronic condition. And I'm going to use diabetes as an example, but we'll illustrate throughout the talk different examples as well. So that's me. At the end of the day, in many ways, I left management consulting to really join Welldoc at its inception, because I felt that we could make a difference in the lives of people who suffer from these chronic conditions. And in many ways, that's what drives me on a day-to-day basis. So I hope to share some of that passion and journey with you today. All right, so one slide and only one slide on Welldoc, just so you have context of who we are, because then what I say is going to make a lot more sense. But imagine the life of a patient with diabetes, okay? So the patient themselves, they have to manage all kinds of vectors throughout the day. They have to manage their glucose, they have to manage their medications, they have to manage their activity, what they eat, how they sleep, their symptomology, and there's this wee little thing called life that gets in the way from time to time, right? At the same time, I considered myself a little bit of a nerd. I would take my data into my doctor. I would actually graph it. But what's the doctor going to do in a 2-minute office visit, right? The human eye isn't trained to do that kind of pattern recognition. And so, you know, it's a little bit of garbage in, garbage out. Hey, how's your glucose been the last 3 months? I don't remember what happened yesterday, let alone the last 3 months, right? So when you think about it, the system today isn't geared towards the management of these types of conditions. And so we asked a very simple question. We said, if you could intersect the patient at the point of care, I'm sitting in a restaurant, I measure my glucose, and my glucose is 212, okay? What do? What should I eat? What can I eat? Maybe if they don't have healthy food choices, maybe I have to eat half a portion size to keep my glucose in range. So you start to think about the questions that a patient needs to answer moment by moment every day of the week. And we said if we could intersect them with providing them real-time coaching. So if my glucose was high, but I'm on metformin and Januvia, versus the same person, another person whose glucose is the same high value, but perhaps they're on a different drug regimen, could you actually provide them precise clinical guidance on what to do? Because the clinical pathways to treat those hyperglycemic values are different necessarily based on the meds that you're on. And we said if we could do that, but then if we could take all of the data and if we could run it through evidence-based medicine software, okay, and if we could tell the healthcare provider, their doctor, could be their cardiologist, could be their nephrologist, whoever it is, the constellation of care around the patient, if we could tell them, hey, doc, this is where your patient was, this is where they are, this is what's changed, this is what you should do against evidence-based medicine, but you do what you think is right, you're the doctor. If you could just do those 2 things, could you make an impact in both health outcomes, the numerator, but could you also impact the denominator, costs? And what we found was astounding, and we'll talk about that journey. But in effect, what Welldoc does is we integrate technology and personalization into the management of chronic conditions such that we're bringing the provider and the patient closer together. We're bringing them together to stand on technology's shoulders and reach further and do better, right? So today, we manage a plethora of what we call the cardiometabolic conditions. So you see those conditions across the top, ranging from diabetes, pre-diabetes, all the way through hypertension. You start to think about it, right? 70% of type 2 adults today in the United States also have hypertension. And they don't want to go to 2 different places to manage their health. They want to go to one place, right? So hypertension, heart failure, behavioral health. So you can kind of see this platform of this cardiometabolic conditions, and we integrate real-time and actionable insights into those living with these conditions. How do we help them make the moment-by-moment choices that they need to make? And how do we help their healthcare providers, if you would, optimize the therapeutic pathways for those patients going forward, right? We'll talk about that as we go forward. So the system is really built to support the 3 actors in this equation. One actor, of course, is the patient. It's an app, software as a medical device, what the FDA calls SAMD, okay? The second portion is what we call the Smart Visit Report. This is the data and insights and the clinical decision support that goes to the healthcare provider, integrable into their EMR flow, visible on a fax, however they want it. We're not there to tell somebody you have to use it this way. Let them use it the way that they want to use it, in the way that makes most sense for their workflow. And of course, the third leg of the stool is the enterprise. Could be the health plan, could be the health system, could be the insurer. They're the people who are actually benefiting, if you would, from the reduced ER visits, the reduced acute utilization events, right? So there's an economic ROI and advantage of these as we look at how these solutions manifest, right? So that's kind of who Welldoc is. Okay, so what we're going to do is we're going to cover a couple of things. And by the way, if there's things that I say that don't make sense, I'll try my best to, if I'm speaking in clinical parlance, and it doesn't, just raise your hand and say, I didn't get that, right? Please interrupt and make any questions and comments along the way, because this has got to be beneficial for all of us. So we're going to establish the rationale for digital health in the first place, okay? And in doing that, we'll describe the equation that leads to better health outcomes, and we're going to explore the role of sensors, all right? We're going to explore how sensors can actually accelerate the delivery of value to both the patient, the provider, and the healthcare system. And we'll illustrate with some of these insights how this can actually manifest in the context of diabetes, okay? So when you think about it, our opportunity space is actually born from the convergence of several things. So the first of these things is the fact that even before COVID-19, we were using the word pandemic for diabetes. We're lucky here in the United States, it's 12.7% of our adult population has diabetes, according to Truven Analytics, IBM Watson Health. If you go to India and China, the numbers go up to 14, 15, 16%. If you go to the GCC, which is the Gulf Cooperation Council, means Saudi, Bahrain, Kuwait, Abu Dhabi, Dubai, Jordan, etc., it's 34%. But 34% of people have diabetes, okay? And it's actually interesting. I remember one of my recent, not so recent, but recent trips to Saudi Arabia to meet with the old king who passed, and his doctor, Khalid Al-Rubian, who's the head of the Saudi Diabetes Society. The king passed away from diabetes complications, right? And I remember leaving, and the king said, now you know why we wear our white robes, it's to hide our bellies. And I said, Your Majesty, should I laugh or should I cry? He said, you should cry. Waist circumference is the #1 predictor of type 2 diabetes. And the CDC says that 1 out of every 3 born after the year 2000 is going to develop diabetes in the United States. So it's pretty bad. At the same time, diabetes is a disease that requires what I call the frequent teachable moments. So an important variable, and we'll discuss it in great length throughout the presentation, is what's the frequency of interaction between the patient and their digital health system, okay? So imagine, for example, if I were to put Andre on the street and say, hey, Andre, I'm going to blindfold you, but I want you to walk to John Wayne Airport, okay? And you can only take the blindfold off every 3 hours, right? The probability that you get to the airport in a reasonable amount of time, right? Okay. Whereas if I play the same game and say, Andre, you can take your blindfold off every 5 minutes, what's the worst that's going to happen? You're going to walk in the wrong direction for 5 minutes, autocorrect, and you're going to zigzag your way there, right? So in this case, the frequency of intervention, right, is actually something of note. If we can improve the frequency that a patient engages with their own health, then we can actually make a difference, if you would, right? At the same time, and by the way, these are the statistics that I just went through. It's a staggering impact. So today, it's $327 billion in the United States. By the way, between friends, our total healthcare spend in the country is about 1/6 of our GDP, right? So between friends, it's about $20 trillion. So let's just say $3.5 trillion. 10% of that is this one insidious disease. And it need not be. It need not be. There are things that patients and providers can do to avoid these expensive complications with diabetes, right? Okay, so that's the first factor. The second factor is we didn't know that the winds of healthcare reform would be behind us. Yeah? So going are the days of what they call fee for service. Your doctor gets paid to see you, right? Versus pay for outcomes, a value-based reimbursement, where your doctor's going to get remunerated if they get your blood glucose, your blood pressure, and your LDL cholesterol to goal. Well, now wait a minute. So I eat the extra slice of pizza every day? My doctor's never going to get paid, right? That equation doesn't seem to make sense. And so there has to be accountability. There has to be accountability on both the healthcare provider as well as the patient. So I'll tell you a story, real story. So every year, in fact, it's happening right now in Barcelona. Anybody ever been to GSMA in Barcelona? Clint, I know you have, yes, yeah. So GSMA is the largest wireless show in the world, okay? And Barcelona is one of the few cities that can accommodate that kind of, everybody descends from around the world there. And a couple of years ago, they asked me, hey, can you give a keynote? We want to do something on digital health, mobile health. I said, sure. But they gave me the keynote on day 2. On day 1, they gave it to a painter. We're all like, well, okay, who picked this guy, right? And you know, it's the who's who in the audience. It's all the wireless CEOs, it's all the health ministers. I mean, it was quite an august audience. And this guy walks on, he was from Avignon, South Central France, okay? And he walks onto the stage, you know, wearing his little beret. And he puts up his first slide. And this guy specializes, by the way, in Renaissance-era paintings. So he puts up his first slide, and the first slide is a Renoir painting of a doctor's office in the 17th century. Well, when he looks at the audience and he says, can you tell me what's wrong with this picture? Silence. Well, no, tell me what's wrong with this picture. So somebody in the front raises their hand. No, that's not what it was. And he says, he takes his stylus and he traces the size of the doctor and he traces the size of the patient. And the way Renoir painted it is the doctor was 3 times the size of the patient. Interesting. And then he says, look at the lighting. And there was a lamp on the doctor's desk and it was shining on the doctor's face and the patient was in the shadow of the doctor. And we're like, son of a... This guy's actually going down to the atomic level of what was wrong with healthcare. And then he looks at the audience and he says, hey, all of you guys, all you smart people, technology democratizes access to healthcare knowledge. What used to be in the doctor's head is not just in the doctor's head anymore, right? So I asked the question, okay, raise your hands. How many people have been to the doctor in the last, 6 months for anything? Raise your hand. Come on, yeah. How many people went to the internet first? Yeah, there you go, see? Technology democratizes access to healthcare knowledge, right? And so we can't ignore that. We can't ignore consumerism. There is a role. Now, if I have a hypoglycemic reading, I could go to Google. Yeah, I'll get 500 responses on what to do, 499 of which may not even be applicable to me. So yes, we have to embrace the fact that technology allows us access to this knowledge, but we have to do it in a responsible way. We have to do it in a way that's driven by clinical evidence, that's driven by patient safety, et cetera, right? So, yeah, you look at all the research, right? Look at the trends here for internet-related health searches. And you can see, you know, any health-related activity, you can see the trend over the last couple of years. But look at the uses on the right? Using the internet for any health-related activity, health information online, looking at your health records, or communicating with the doctor. We saw that hugely during COVID, right? All of a sudden, you know, at Welldoc as a company, we would cover telemedicine for over a decade. Nobody used it. And all of a sudden now with COVID, oh my God, look, I have this teleconsult. I don't have to take half the day off work and take my child. It's really good, right? Okay, so that's number 2. So number 3, this is a funny one. Does anybody know on average how much it costs to bring a new drug to market? Just guess. Average. Yeah, so it's funny, when I ask that question, Andre, a lot of people say, oh, 10 million. I'm like, wrong unit. Yeah, billions. Yeah, it's in the 2 to 3 to 4 billion, depending on what and you know why? Compound number 1 isn't stable. Compound number 2 kills rats. Compound number 3 had adverse events in humans. It's the amortized cost of failure until they actually get something through the hands of the FDA, right? And there's a number, in fact, there's 2 numbers that the pharmaceutical industry is measured on. I'm oversimplifying. One is called compliance, one is called persistence. What % of fills and refills are done at the 6th and 12th refill point? And it's actually pretty bad. The curve goes down. It goes down quite a bit. And that area above the curve is what we call lost revenue. This is prescriptions that should have been filled by patients, but that they weren't filled. So think about it. Doctor writes a prescription for their insulin. 78% of those prescriptions are filled, by the way, and 22% are never filled. And it's not because they forgot. If it were that easy, J&J would have sold alarm clocks with their drugs. That's not why people don't fill their drugs, right? Maybe they can't afford it. Maybe there's a side effect that they don't want to talk to their doctor about. It's embarrassing. There's so many reasons why people don't fill those scripts. And yet, in the case of insulin management, there's a number called treat to target ratio, which is the amount of insulin that should be taken by a patient divided by the kilograms mass of a person. And there's a certain range for each insulin manufactured. We're consuming far less than we should be consuming today. Almost a third, okay, to 40% less than what we should actually be consuming. And you know what's happening in the background? When you're not taking that right amount of insulin, nephropathy, retinopathy, neuropathy, heart attacks, kidney failure, all this stuff is happening in the background, okay? And so we're not talking about opioids. Don't get me going on that one, right? We're not talking about wrong prescriptions. We're talking about legitimately your doctor prescribed something that you should have been taking that you didn't take, right? So there's a huge opportunity here. If you're the pharma CEO and you have $1 extra to spend, would you rather spend it on Abyss, $3 billion that may never see the light of day with the FDA, or do you spend it on uplifting what you already have in the market? The answer is pretty obvious, right? Where do you get your highest ROI? You get it from the second place. And so there's an investment conundrum that actually works in our advantage. We're actually seeing medication adherence rise to where it should be, where people are taking the meds at the prescribed doses by what's prescribed by the doctors, and they're keeping out of the ER, and they're keeping out of acute utilization events. Those are the expensive things that you're reducing cost for, right? And then lastly, no surprises, there are more cell phones on the planet than toothbrushes and toilets. Economist 2015. If you don't believe me, go check it out. And you know, the cell phone is a very cool thing. It knows no socioeconomic boundaries, right? The rich have it, the poor have it. The smart have it, the not so smart have it. Everybody has a bloody cell phone. And they use it in ways that we can't even imagine, right? And so if we can tap into that, if we can tap into the ubiquity, if we can tap into something that provides that kind of, we talk about accessibility and affordability in healthcare, right? There is no better way to reach somebody other than this device that they have. You know what's fascinating, guys, in our patient populations that we serve today? If you think about the Medicaid population, so economically underserved people, they're our highest users. That cell phone is not just their cell phone. That cell phone is the family hub. That's their family PC. That's their family TV. That's everything. So if you can tap into the power of that and do it, again, in a clinically rigorous, safe, all that good stuff way, you can actually make a difference. So you can see here statistics about kind of where the cell phone and penetration of smartphones is going, right? And this is actually really interesting, right? Because if you actually trace the evolution of all these disruptive technologies that have hit, starting with radio to telephone, whatever, cell phones have gone through the roof everywhere in the world, right? So we're latching on to something that I almost call it inevitable. There's an inevitability of the cell phone as a mechanism, right? As a platform to then offer these types of services. So, but this is what's happening at the macro level, okay? This is all happening at the macro level. At the micro level, this is what's happening every day with the patient and the doctor. New England Journal of Medicine calls it patient-physician discordance. Doctor says X, patient hears Y, okay? Real story. We had, in our first clinical trial, we had patients who were on Byetta at the time. Byetta is a once daily injectable wonder drug, reduces hemoglobin A1C quite a bit. but you have to eat when you take it. So your doctor will prescribe it at a meal, to take it with a meal. And if you don't take it at a meal, the mechanism of action, it doesn't exist. And so you had patients who were taking this. Monday morning, took my Byetta religiously, recorded it in my app, great, but didn't record any carbs. Tuesday morning, injection, no carbs, N equals 2. Wednesday morning, timeout. Hey, first of all, I'm glad you're taking your Byetta. Never shame the patient. As soon as you shame the patient, they're done, right? Hey, I'm glad you're taking your Byetta, but did you know it only works when you eat? And they talk to your doctor about switching it to a meal dose that you consume. Meanwhile, the doctor can't figure out, why is this wonder drug not working in this patient, right? So the doctor looks at the prescription. The prescription says, take it at breakfast and no, I meant with breakfast. Patient-physician discordance. And we're not there to tell the patient or the doctor that they're wrong. We're there only to bring the two together. If we can help solve some of these challenges, we can actually move the needle forward. So today, it's kind of a little bit of a square peg in a round hole, right? So diabetes, for those of you who aren't, so just a show of hands, who here is not familiar with diabetes as a disease? Don't worry, if there's no shame here, raise your hand. Yeah, so it's actually quite simple, guys. You eat. Everything that you eat is converted into sugar, is a unit of energy, right? Your liver produces sugar, okay? Your pancreas produces insulin, it's a hormone, okay? And what insulin, in very simplistic terms, okay, is like an agent. It grabs the sugar molecules out of your blood and it converts them to energy, okay? In type 1 diabetes, which is often called juvenile diabetes, your pancreas is kaput. It doesn't produce any insulin, so you have to augment with insulin injections, okay? In type 2 diabetes, it's a wastebasket term. There's so many reasons why you'd have type 2 diabetes. Perhaps it's because your pancreas needs a stimulus to produce insulin, or you've lost its glue effect to capture sugar molecules and then convert them into energy. The game in diabetes is very simple. Oh, this works? Look at that. You got to stay in this range, this axis being your real-time glucose levels in milligrams per deciliter, right? This is your range. You want to be kind of between kind of this safe range. And if you go above that range, these are the bad things that happen. If you go below that range, this is what happens, right? So it's a little bit of a balancing act. And if you talk to ADSES, which is they used to be called AADE, American Association of Diabetes Educators. Now they're the Association of Diabetes and Care Education Specialists. I don't know where they came up with that, but anyway, ADSES. When you talk to ADSES, they say, hey, management of diabetes is actually a tricky puzzle because you have to manage all these things. You have to manage your glucose, what you eat, your medications, how you cope, your psychosocial stress, etc. And you also have to keep your glucose in healthy range, right? Now think about it. For all of you who are engineers, if I poke myself twice a week, my finger, and I get a reading, how is that ever going to tell me what's happening throughout the rest of the week? I can't make that much inferential analysis about 2 data points that then predict what's actually happening, right? It's very difficult to do. And then you say, hey, what's the effect of on my food, on my glucose? What's the effect of my activity? I don't know. I only measured myself twice. How do I know what the possible effect is, right? And so challenge number 2 is, if you think about the majority of the diabetes world today, it says intermittent BG testing. You poke yourself. You're supposed to poke yourself somewhat frequently and periodically such that you get this data and that you can then make the correlational insights between that data and what you've actually done, right? So if you're anybody in the diabetes industry, that's kind of what it feels like, okay? If you're a doctor, it's like, just punch me in the face. If you're a patient, just punch me in the face. If you're a health system, just punch me in the face. It is the largest single cost item that every health plan worries about that they shouldn't worry about because it's solvable, right? So we asked I looked at this chart, which is a fun chart. I don't know if anybody watches the nightly news with Lester Holt. I swear there's a new diabetes drug every day. There's like always a commercial for a new diabetes drug. This is just a chart of all the new drugs that have been introduced in the last couple of years, okay? Just think of how many billions of dollars. At the same time, only a quarter of us are meeting the guidelines for hemoglobin A1C, LDL cholesterol, and blood pressure. Only a quarter of us meet the guidelines. So drugs alone isn't solving the problem. Drugs alone isn't solving the problem. So we asked a very simple question. Are we solving the wrong problem? Are we solving the wrong, I love the picture. The guy's arms broke, but the vase stayed intact. Are we solving the wrong problem? And I would assert that there's only two problems we need to solve. One, we have to get the right data to the right person at the right place at the right time. Now, when you think about it, that problem has been solved elsewhere. Just bring in mobile technology, and we are very good at getting the right data to the right person at the right place at the right time. How many people trade stocks on their phones? Yeah. How many people have their, a home alarm system on their phones? I mean, we do everything on our phone. Well, why not our healthcare, right? But the second problem is a harder one. The second problem says, how do I convert that data to information, knowledge, action, and outcomes? And this requires behavior modification on the part of the patient, right? So I want a continuum. I want data. I want glucose data. I want blood pressure data. I want what you ate. I want how you're feeling, psychosocial data. I want diabetes distress data. I want that data, but the data in and of itself is useless unless I convert it to information, knowledge, action, and outcomes on the part of the patient and their healthcare provider. And if I can fulfill this continuum, if I can actually make this continuum work, then we have a way out of this conundrum, right? So think about this picture now. Imagine I have now, instead of poking my finger, I have what's known as continuous glucose monitoring, CGM, that you hear with, for those of you who watch the Super Bowl, you saw Nick Jonas in the commercial for Dexcom, right? You're wearing a sensor, and every 5 minutes, it's spitting out a glucose value, okay? It's spitting out a glucose value to a receiver or to your cell phone. And now I have basically 288 passively collected data points on a day-to-day basis. And now imagine if I can step back and I can apply the combination of a digital health solution that also tracks my activity, my food, my medications, et cetera, and I start to create the composite picture. Just think of what you can do with that sensor-driven data. In fact, one of the cool things we're working on, guys, I actually look at these Dexcom sensors, the G6 sensors, you wear it for 10 days. It's a 10-day wear period. I can now look at one wear period, and I can use that data to predict what's going to happen in month 6 and month 12. That's predictive analytics. That's really cool. I can actually tell what behaviors are indicative of success versus what behaviors are indicative of failure. Because I have that density and I can train my models to do that, right? So this is the kind of picture you want. Why? This is educational for a patient. They now know not just what is happening, they know why it's happening. They know what the effect of one slice of pizza versus two. Or they know the effect of, I still remember when I wore my very first Dexcom G6 sensor. We were funded by the state of Maryland to do a study, and so, but I kept some sensors. And after we were done with the study, I put my sensor on, I drank a glass of red wine, right? And red wine is supposed to do this to your glucose, but somehow in my body, for some reason, it kind of mutes and comes back down. I'm like, thank you, because that's my favorite. So the next day, I decided to make my favorite South Indian food called a dosa. It's really good stuff, but it's really bad for diabetes. And sure enough, woo, right, it goes up and down. I'm like, okay, we're even, right? No dosas, but I can have all the red wine I want. You hack your diabetes. How cool is that? You're using sensor data to hack your disease. You get insights about you. It's not some textbook you're reading about the population. This is you. It's your body. It's your drugs. It's your food. It's you. That's called personalized medicine. We're actually unlocking the opportunity to do personalized medicine. Because I'm not the norm. I'm me. And my genomics and my whatever they are, I don't know, but you know what? Good, I can drink my red wine. I love it, right? Okay, so that was us. There wasn't any road. There wasn't anybody ahead of us. We had to kind of figure this out. So let's pave this road, not just for ourselves, but let's pave it for the industry as well. So this is fascinating, right? When you think of what's actually happening with digital health, it's exploding. It's actually exploding, whether it's in diabetes, whether it's in hypertension, heart failure management, neurological disorder management like ADHD, whether it's musculoskeletal pain management, whether it's oncology. This thing is exploding in ways that we can't even imagine. And when you actually look at this, those who actually have chronic conditions are the ones who report the highest amount of digital health tracking. So it's not the flu shot, it's not that kind of stuff. It's people who have chronic conditions are most relying on these solutions going forward. Because you have to. It goes back to what I said about frequency of engagement. If you can keep that frequency of engagement high, you can actually stay within the safe range, right? You can actually do what your doctors told you to do. So, yeah, there's a lot of stuff out there. I mean, I don't know, there's like literally 300,000 health apps on the market if you go to the iTunes and Google Android Google Play market. But how do you actually know what's good? So there's a fantastic resource called the Digital Therapeutics Alliance. So for those of you who want to know, dtxalliance.org, dtxalliance.org, go to it, and what the Digital Therapeutics Alliance has done is it's, if you would, assembled a set of best practices and kind of guardrails that say, if you want to be classified as a digital therapeutic, these are the types of things you need to do. This is the rigor by which you need to bring these solutions to market. And you can see some of these things here. I won't go through all of them, but digital therapeutics, of course, you're making a claim. So I'm making a claim about A1C reduction in diabetes. Somebody else may be making a claim about cognition improvement, like Achille Interactive in Boston, for cognition improvement for kids with ADHD. Or somebody may say a claim like Paratherapeutics for substance abuse disorder. And I'm reducing the dependency on substance overuse, if you would, right? They create a medical intervention that's driven by software. So these are what the FDA calls SaMD, or software as a medical device. Typically class 2, 510K cleared products. So they fall within that risk category of class 2. Of course, they incorporate all the things you would want to do if you were building good software anyway. So whether your favorite software development framework is CMMI level 4 or 5, or it's IEEE 62304, whatever your favorite process is for developing software, do it with something that's traceable to a quality management system. Build your software in a way that's repeatable, scalable, measurable, traceable. That's what the FDA and the regulators look for. They look for that level of excellence, just like you were building and bringing a new drug to market. They're going to look for that same kind of rigor, but now it's the rigor that's applied to building software. And you can kind of see some of these things. Patient privacy and security. We have to think about it. This entire industry shuts down if we have one breach. We have one breach. Everybody will lose credibility. So cybersecurity, whether it's SOC 2 certification, whether it's high trust certification, right? Whether it's the IEEE standard 2126, Dr. Klonoff is here, and you're going to hear from him on that momentarily. There's an opportunity to ensure that as we connect a CGM sensor, a Bluetooth weight scale, a Bluetooth blood pressure cuff to this digital health tool, that we're safeguarding this information. And we're being responsible. We're being responsible in how we manage that cybersecurity. So you can see here these 10 principles. I put these 10 principles up, folks. Why? This is the rigor by which you want to embrace a solution. And then you can actually show the outcomes, et cetera, right? So when you think now about, fine, I have sensors and I have digital health, I think about these 5 V's that we always associate with digital therapeutics. And you can see these. I'm exponentially increasing the volume of data I'm capturing, right? So there's a huge volume of data. The variety of the data is heterogeneous data. So I'm collecting glucose and food and weight and blood pressure. All these different vectors of data. The velocity is coming at near real time. How cool is this versus going to the doctor and doing a once annual exam where your data is coming once a year? Now you're getting real-time data that can actually inform real-time actions, right? And real-time interventions. And of course, now that these data are coming from connected devices, the veracity, the truth associated with those data points is high. By the way, Germany is the first country that actually produced the digital formulary at the national level. And in the German formulary, you have to connect to a trusted medical device in order to be reimbursed. And now NHS England and TG Australia are all following suit. France is following suit. Spain is following suit. FDA is considering following suit. How do you reimburse for these things if the data itself is not trustworthy, right? And of course, when you have these 4 V's, that's how you generate the last V of value, right? It's these 4 V's that combine to give you the 5th V, which is value. So what do you do with this data? Okay, fine, you're gathering all this data, high volume, high variety, velocity, all that good stuff. So here's a framework I wanted to share with you. We call it IDEA, and you'll see why in a second. So look at the axis. The x-axis is the presence of data, I have it or I don't, right? And the y-axis is your analysis intent. So I know what I'm looking for and I don't know what I'm looking for, so play it out. The bottom quadrant, I have data, I know what I'm looking for. We call this as informatory analysis. Informatory analysis answers the English question, tell me what happened. It looks back at data and say, okay, well, show me the number of glucose readings that were in range versus out of range, example. Or show me that pattern on a weekday versus a weekend. Or show it to me for a male versus female, or above 65, less than 65. You cut and slice the data however you want, right? It answers the question, tell me what happened. Once you've informed yourself, you now go north, and we call this as D-discovery. D-discovery says, okay, I have the data, but I don't know what I'm looking for. Can I learn something from the data that I wouldn't otherwise know? This is the realm of statistical pattern recognition. Can I detect a pattern of interest? It could be a medication pattern, it could be a glucose pattern, it could be a testing pattern, an exercise pattern, it could be a good pattern or a bad pattern. And if it's a good pattern, maybe I want to emphasize it. Good job. If it's a bad pattern, never shame them. Hey, this is what happened. You may want to try this instead because this ain't working or it's causing risk, right? So whilst this answers the question, tell me what happened, that answers the question, tell me why it happened. You're answering why. And once you've discovered your pattern of interest, you come down to this quadrant. Truth be known, we wanted to call this P-predict, but IDEA doesn't spell anything and IDEA does. So we said, let's call it E-extrapolate, the marketing in me, right? Let's call it E-extrapolate that says, can I predict? And now can I say when it will happen? And this is where you apply machine learning models to use predictive analytics to say, can I predict if somebody's going to go hypoglycemic based on their last 24 hours of glucose trends? Can I predict that this is what the effect of exercise, or this is what the effect of food, or this is what the effect of their medications, dosing, et cetera, is on their glucose? Sure, I can. And actually, I can predict that with very, very high accuracies, right? So we call it here as E-extrapolate. And then, because this is all software, you now have an ability to adapt. So the FDA just put out a guidance document on the inclusion of machine learning algorithms inside a SAMD product. What's the way to think about it. If the FDA clears a drug, Januvia is Januvia. The biochemical formulation doesn't change over time. But now you're introducing software as a drug where the algorithms may adapt and change. How do I know that it's safe for a patient? How am I going to do my usability testing? How am I going to do my safety testing? So they've actually put out a guidance document that suggests this is how we think you should embrace. So I'm going to show you an example or two of that. It's kind of very cool. So here's an example of informatory analysis. This is dense data, 288 data points every day. And you can see people look at things like time in range. How many of those readings within a 24-hour period fell within the range that they're supposed to be? The green, right? And how can I visualize that? How can I visualize that trend over time, right? One of the things that Dr. Klonoff, who's a CEO of Diabetes Technology Society, who will be here with us on the panel after lunch, is this is a single metric, time in range, but there's also time below range and there's time above range, which are your danger zones. And they've come up with new metrics like glucose risk indicator, GRI. that create a composite view of risk, a much more insightful view of risk. I could actually plot the risk pathway for a patient. In fact, I could do better than that. I can plot the risk pathway for a cohort, my entire population, and I can say at a pop health level, are they doing better? Are they getting better? Where's the trouble spots? I can use that. Oh, these people, leave them alone. They're doing great with the digital health tool. No, these people, pick up the phone and call them. They need the help. All of a sudden, it creates a mechanism to use that scarce resource, which is the nurse, because a nurse doesn't have infinite time, right? That nurse or educator can pick up the phone and call the patient who actually needs the help. So there's informatory analysis. There's discovery. This was a fun one. We asked a very simple question. Is there a pattern associated with hemoglobin A1C drop associated with how long you wear the sensor for? And how continuously you wear? Do I need the sensor to be there all the time? There's cost associated with that, so it's a very logical question to ask. Or can I wear it intermittently and still get value? Oh yeah, you can still get quite a value. By the way, for those of you who don't know, hemoglobin A1C, it's the standard metric of diabetes wellness across the globe. In simple English, you go and you get a vial of blood drawn, they centrifuge it, and they come back with a number. The number tells you the percentage of, by volume, sugar in your blood. So the ADA target is 7%, which kind of simply means that 7% of your total blood volume is sugar. If you don't have diabetes, by the way, that number is typically 5.5, right? Ish, right? So 5.5. Here's what's important, though. Every delta of 1, 7 to 8, 8 to 9, is a 42% increase in the risk of heart attacks, kidney failure, blindness, amputation, stroke. If you can keep that number below 7, you will keep those downstream complications at minimum. You will reduce those downstream complications a lot. A drug is heralded by the FDA if it drops that number by 0.5. That's the marker for a new drug. Show that it created a delta of 0.5. Look at these numbers, guys. Look at this axis. This is what the FDA requires, okay, right there. Look at this. These are huge. This is 4x what's required for a new drug. Why? The patient's doing what they should be doing throughout the day. They're staying within that safe range, right? Frequency of intervention. So this one, extrapolate and adapt. We had a lot of fun applying some advanced mathematical algorithms to this, which is, okay, I have a CGM trace. Okay, here it is. What does it mean? A trained endocrinologist knows exactly what it means. They'll be able to dissect that signal and tell the patient everything to do. But a primary care doctor, no, not for any fault of their own. Think about it. A primary care doctor is the front of every problem. The patients come to them not just about their diabetes. They have a headache, they have a rash, they have a, by the way, how's your glucose? So they're the front line. And they're not trained on how to do all of this pattern recognition. So we said, hey, what if we took the CGM trace and we applied machine learning to it such that I could actually pick shapes of interest? Could I actually detect a pattern of interest? In fact, can I use an AI system to detect and classify? So now I have classifications. Okay, I have a signal, goes up a little bit, stays long, high a little bit, comes down, not bad, versus something like this, that's really bad, or something like this, which is even worse. You never want to go hypo, right? So we said, can we build a system to automatically detect shapes of interest? And then, based on these shapes, could we actually publish those in the app and tell the patient at the end of the day or the end of the week, hey, here's 2 things you can learn from. One was a good pattern, keep it up, good work. One was not a good pattern, you may want to avoid doing this, whatever it is, right? So now think about the power of this kind of sensor data, right? This kind of sensor data to actually illuminate these pathways for the patient and illuminate what's going on for the healthcare provider. We had fun with this one because we actually took it and we said, what does the machine detect in terms of patterns and shapes, and what does a human? So we actually looked at a bunch of different healthcare providers, 6 doctors, endocrinologists, and we said, how would you classify this signal? And you can see here the correlation in the bottom between what the machine picked and what the humans picked. This is the opportunity for us. You know this fellow Dr. Eric Topol, he's not far away from here in Scripps in San Diego, one of the luminaries in the space. People would ask him all the time, is digital health going to remove the need for a doctor? And he goes, no, hell no. But a doctor who uses digital health will replace a doctor who doesn't. Think about that. This becomes an adjunct tool for providers. You know, I used the analogy the other day, and we were flying across the country. It was a beautiful night, looking up at the sky, and you see a point of light. And you're like, oh, it's a star, right? The more astute will say, no, it's a planet. But it's still a point of light. Whereas when you look in the Webb telescope, it's an entire galaxy. Maybe it's a set of galaxies, right? The Webb telescope is to the astronomer what digital health is to the doctor. It lets them see things that are not visible by the naked eye. It lets them look underneath the covers of what's happening with that patient. That's cool. Because my doctor, he's a smart guy, but he has all this data. He's like, oh, now I know what's wrong with you. Okay, well, we can work on that. Versus, hey, you know what? I'm going to prescribe you this. Come back and see me in 6 months. We'll see how it's going. Okay, yeah, good. It's a different way of practicing medicine. It's a very different way. It's an adjunct tool to give providers, and they're trained clinically. They don't always have to do what the system says. It's up to them what they do with their patient, right? But to have this kind of information at their side, providers have told us, you know what? They're in and they're out. We have a room full of 9, 10 patients waiting. Things can be forgotten. And tools like this are helpful. They're helpful for us to make best use of our clinical training and clinical judgment to guide the patient in the manner that's best going forward. So here's examples of all kinds of sensor-driven stuff that's there, right? You can see whether it's all the fitness trackers. Now I can actually use these trackers for conditions like that require activity. So think about post-surgery, and think about, for example, getting your knee surgery, and I want to make sure that I'm creating the right angular movement. And these are all things that I can do very easily, right? And think about weight is so critical to so many chronic conditions. Whether it's congestive heart failure, whether it's hypertension, whether it's diabetes, weight is such a central variable. But now I can bring in that weight data and I can actually coach patients on what to do. And of course, now I have these things, right? And tomorrow, the back of this is going to have a series of photo-optic sensors. They're going to tell me a lot more, lab on a chip as I call it. Can you imagine that? Now it's a world of non-invasive. If I'm Quest and LabCorp, by the way, the lab companies, I'm shitting bricks in a little bit of a way, right? Like, they're going to put me out of business. Why would I ever go and do this if I can do it all continuously, right? And you know what? The accuracy is not there today. Granted, it is what it is, but Moore's Law helps you here, right? Every year, the error rate's going to reduce by 50%. They're going to get there, and they're going to get there quickly. And so we are at the cusp. We're at the cusp of transforming this healthcare conundrum by embracing technology. Here's 2 examples of advanced ones I wanted to just share with you. One is Echo Health. Some of you may know them out in the Bay Area. But they do the electrocardiogram and the phonocardiogram signals with their digital stethoscope. And they've actually used these algorithms to now train to detect AFib, murmur, EMAT, so electromechanical activation time. For S1, S2, S3, and S4, all 4 heart signals, which is pretty wild when you think about it. It's pretty amazing what they've been able to do. MedRhythms, this is one that I've come across recently in the Digital Therapeutics Alliance. They actually use music therapy. You know when you listen to a nice beat, your finger starts tapping? There's a reason for that. There's an auditory autonomic response. So they actually use music therapy to help people who have post-stroke neurological disorders to walk properly. And they actually are getting their FDA clearance. It's going to be the first music therapy to be cleared by the FDA because it's going to show an improvement in cognition, it's going to show an improvement in reduction in falls. It's actually going to be labeled as a drug by prescription only, MedRhythm. So I just wanted to provide you these examples because it's not just diabetes, right? There's all kinds of stuff happening in this space, right? So at the end of the day, what's the value proposition? When you look at this chart, right, the x-axis is frequency of intervention that we talked about earlier on. The y-axis is the intensity. So for example, surgery is up here. Why? Hopefully you don't do it very often, but when you do it, it's a very high cost and it's a big deal. Whereas back pain is down here. Why? You may have back pain every day, but you pop a couple of Advils or Aleve and you're good for the day. The problem with chronic diseases, they're stuck up here. They're stuck here in this quadrant because people don't engage at the frequency they need to, and they end up in the ER. And what digital does is it shifts that cost basis down. You're taking high cost, low engagement, and you're converting it into high engagement, low cost. So I've been saying this for 2 decades now. The blockbuster drug of this century is the engaged patient. Get them to do what their doctor has told them to do, and they'll do better, right? This is exactly what that is, right? So yeah, is this the future? Could be, right? Just don't mix up the phone and the suppository. Yeah, this is the future, right? Eric always says, the iPhone came out when? 2007? We're what, 23 now? We're 16 years in? That means the iPhone generation is 1 year away from going to college. And they're 5 years away from going to medical school. And do you think they're going to want to graduate with a stethoscope that goes to-thump, 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 when they can see a perfect EKG signal on the back of their phone? Inevitability. There is an inevitability of this. We have to guide it. We have to do it responsibly. We have to harness the thinking behind what we can do with sensors, etc. And then we can actually bring something forward. So I'll leave you with this one last thought, which is, I think the worst thing about having a chronic condition, folks, is you feel a sense of loneliness. You feel alone. And when you're lonely, bad things happen. It's this spiral abyss of misery. And if technology is what can lift people out, if technology gives people an opportunity and gives them hope that there's a way forward, then we all feel like we've done something good in our jobs. Thank you.